so good morning everyone. Today we will continue with our presentations on the Neuroradiology chapter from the core radiology. Now we reach the neck infections. Dr. Sasgar will talk to us about it. Thank you.
Good morning everyone. Today I will talk about the neck infection. Start with the facial anatomy of the retropharyngeal space. The retropharyngeal space is the potential space located posterior to the pharynx, separated from the pharynx by the pharyngeo-basilar fascia. The retropharyngeal space extends from the base of the skull to the upper mediastinum. Directly lateral to the retropharyngeal space are carotid and parapharyngeal space. Alar fascia, it's also separated another potential space from the retropharyngeal space, which is called danger space. Danger space acts as a trap door for infection to travel all the way from the neck to the diaphragm. Neck infections and inflammation. Midwing angina is the cellulitis of the floor of the mouth. It's an infection that can involve submental, sublingual, and submandibular space. The tongue can rapidly become posterior displaced, so ensuring airway patency is a clinical priority. On imaging, there is a stranding and swelling at the floor of the mouth. Contrast enhanced cervical CT, there is a thickening and increased attenuation diffusely on the floor of the mouth, with associated with the fluid collection and bilateral cervical lymphadenopathy. Retropharyngeal abscess is potentially life-threatening infection involving the retropharyngeal space, which require prompt diagnosis and aggressive therapy. Retropharyngeal abscess in children most commonly due to the pharyngitis, and in adult most commonly due to the penetrating injury like fishbone ingestion or instrumentation. On the lateral neck radiograph demonstrate marked thickening of the perivertebral tissue. Prevertebral tissue.
Normally, how much should it be prevertebral?
7 mm at
less
from
than the width of the vertebra.
Yes.
And القرن بالvertebral قدامه. You compare it with the vertebra adjacent to it. It should be less than the width of the vertebra. Here it's almost the same, maybe even more.
Yes. Sagittal and contrast axial enhanced CT shows a peripherally enhanced fluid collection in the retropharyngeal space, causing effacement of the right oropharynx. Peritonsillar abscess is the most common deep neck infection, almost always secondary to acute or chronic tonsillitis. In this axial CT image shows multilocular low-density collection beneath the enlarged right tonsil, which is displaced medially.
طبعا clinical history here is of very important consideration, because if you don't have history, this can be anything. Can be malignancy, can be infection, can be due to foreign body, can be due to lymphoma, whatever.
Yes.
Clinical history is very important in these conditions.
Yes. Lemurs Syndrome, also known as post-anginal septicemia, refers to the thrombophlebitis of the internal jugular vein with distant metastatic sepsis in setting of initial oropharyngeal infection, such as pharyngitis, tonsillitis, with or without peritonsillar or retropharyngeal abscess. This is an example of the Lemurs Syndrome. Axial and coronal formatted contrast enhanced CT scan of the neck and upper chest, showing thrombosis of the internal jugular, subclavian, brachiocephalic, and superior vena cava, with a small residual pocket of air inferior to the jugular foramen. Also, there is swallowing of the swollen, heterogeneously enhanced right submandibular salivary gland.
وين الاير اللي من الجاكيلر foramen؟
هنا.
وين الجاكيلر foramen؟
هنا هاي jugular foramen.
No.
مو هاي internal.
Second
هذا.
image. Second.
Second.
Up. اكو سهم صغير بدي اشوفيه. فوق صعدي بعد.
Yes, high. Yes.
And this is the lip. So you just don't read. You understand what you are saying.
Yes.
Okay.
Cystic lesions of the neck, floor of mouth cystic lesion, ranula are rare, benign, ranulus, cystic lesions that occur at the floor of the mouth as sublingual or minor salivary gland retention cyst. Axial CT at the level of the mandible shows cystic lesion at the left sublingual space.
What's the meaning of ranula? You know? شو معنى؟ Frog. ليش سموه frog? In a clinical examination, it looks like a frog in the floor of the mouth. المريض يشيل لسانه يطلع فشي مثل الضفدع على الجو. يسموها ranula. اللي هي Latin for frog.
Dermoid epidermoid is a teratomatous lesion that contains at least 2 germ cell layers, while an epidermoid contains only ectoderm. On CT, both dermoid and epidermoid will appear as a fluid attenuation lesion, most commonly in the midline of the floor of the mouth. A pathognomic MRI finding of dermoid is a sac of marble appearance from floating fat globules. In the absence of this finding, epidermoid and dermoid can be indistinguishable in this location on MRI. Thyroglossal duct cysts are the most common type of congenital neck cyst and pediatric neck mass. They are typically located in the midline and are most common midline neck mass in young patients. They can be diagnosed with multiple imaging modalities including ultrasound, CT, and MRI. Sagittal and axial enhanced CT shows thick-walled peripherally enhancing cystic structure in the midline inferior to the myeloid, which consists with the infected
وين myeloid?
myeloid.
وين؟
يعني it is inferior to it.
myeloid هو الفلور of the mouth.
Floor of the mouth, yes.
يعني انزلي بعد شوية. Okay.
هنا.
This is it. From the hyoid to the mandible.
Yes.
Okay.
Cystic metastasis, papillary thyroid cancer, as squamous cell carcinoma from the base of the tongue or the tonsil metastasis to the floor of the mouth region. These metastases tend to be cystic. Solitary parotid region cystic lesion, like first branchial cleft cyst, is rare and is usually located near the parotid or the external auditory canal. May appear as a simple cyst, however imaging is variable and content may be heterogeneous, especially if superinfected. Cystic lesions about mandible. Second, branchial cleft cyst are a cystic dilatation of the remnant of the second branchial cyst and branchial cleft along the second branchial fistula, and sinuses account for 90% of all branchial cleft anomalies. Axial coronal and axial contrast enhanced CT shows water attenuation cystic lesion at the angle of the left mandible with minimal peripheral wall enhancement. This cyst is in classical location of the second branchial cleft cyst posterior to the submandibular gland, anterior to the sternocleidomastoid muscle, and closely associated with the carotid sheath. Submandibular or masticator abscess. Submandibular or masticator abscess may arise from the dental disease, most commonly suppurative adenopathy or spread of adjacent salivary gland infection. On imaging, an abscess appears as a regular thick-walled peripheral enhancing fluid collection located inferior to the mandible. Adjacent stranding of the cervical fat is usually present. In addition to antibiotic, aspiration is usually a key component of treatment. Axial and coronal contrast CT shows peripherally enhancing irregular fluid collection abutting the right mandible with associated stranding of the subcutaneous fat. Other neck cystic lesions, lymphatic malformation like cystic hygroma and cavernous hemangioma. Cystic hygroma is the most common type of the lymphatic malformation. Thorn walled cyst, the typical location of the thorn walled cyst is midline of the nasopharynx. Miscellaneous neck lesions like lingular thyroid is a specific type of ectopic thyroid results from the lack of normal caudal migration of the thyroid gland. Is most commonly seen in the women and is susceptible to the thyroiditis and cancer. On this image we see the oval or ovoid hyperdense lesion in the floor of the mouth or base of the tongue is represent as the lingular thyroid.
Before that, if you have a patient with lingular thyroid or ectopic thyroid,
yes,
what do you do before writing your report? أهم شيء, the most important thing, you scan the normal thyroid, the neck. If there is a normal thyroid, you write thyroid present at the thyroid bed, okay? Because this might be the only thyroid the patient have. Sometimes you don't see any thyroid in the thyroid bed. So if the surgeon removes it, he will end up with hypothyroidism. They should, if there is no normal thyroid in the thyroid bed, they remove it and re-implant it somewhere else.
Yes.
يعني يشيلوها ويزرعوها.
Yes.
Okay.
Larynx. Regarding the anatomy of the larynx has a cartilaginous skeleton consists of the thyroid, cricoid, and arytenoid cartilage, thyroid, cricoid, arytenoid, and the covering epiglottis. Radiologically, larynx is divided into supraglottis, glottis, and subglottis. Supraglottis extend from the tip of the epiglottis to the superior surface of the true vocal cord. Subglottic, it extends from the inferior surface of the true vocal cord to the inferior surface of the cricoid cartilage. Cross-sectional CT is provide excellent information about anatomical details of the larynx and surrounding structure. Here is their laryngeal ventricle. It's seen inferior to the free edge of the false vocal cord and true vocal cord. False vocal cord is mucosal enfolding superior to the laryngeal ventricle. Benign and malignant disease of the larynx. Vocal cord paralysis is commonly seen due to iatrogenic trauma after the neck surgery, or maybe to do secondary to the mass lesion in the thoracic and mediastinum, causing within the course of the vicus and left recurrent laryngeal nerve. On the CT imaging shows thickened medialized epiglottic fold and enlargement of the piriform sinus on the affected side. The left recurrent laryngeal nerve is most commonly affected nerve. Imaging of the vocal cord paralysis should extend from the base of the skull, skull base to the level of the left pulmonary artery to cover full course of the vagus and left recurrent laryngeal nerve.
What kind of surgery or iatrogenic trauma that makes most common injuring the vocal cords?
Thyroidectomy.
Almost always it's a thyroidectomy. They injure the left recurrent laryngeal nerve.
Yes. Laryngeal is dilatation of the laryngeal ventricle, which may be caused by high laryngeal pressure, and patients with a cough have increased risk of developing laryngeal. Laryngeal may be filled with air or fluid. An important differential consideration is ventricular obstruction by neoplasm, most commonly squamous cell carcinoma, which typically causes fluid-filled laryngeal. Laryngeal cancer, the vast majority of the laryngeal tumor are squamous cells of the mucosa. Less common tumors of the larynx, such as lymphoma and chondrosarcoma, may be submucosal. The most important imaging determination is if tumor is supraglottic, subglottic. About 30% of the tumors are supraglottic, and 65% are glottis, and only 5% are subglottic. Laryngeal trauma, blunt trauma to the neck may compress the larynx against the cervical rib. Laryngeal trauma may also cervical spine as also result from the intubation, which can cause a retinoid dislocation. Thyroid cartilage and cricoid cartilage are most susceptible to the trauma. Thyroid cartilage fracture CT in bone windows demonstrate minimally displaced fracture of the thyroid cartilage. Paranasal sinuses. Coronal and axial CT provide excellent information about all paranasal sinus. Maxillary sinus is the largest paranasal sinus. It's a pyramidal in shape, and its apex toward the toward the zygoma, and its floor formed by the floor of the orbit and roof of the orbit, and medial wall
formed by the floor
of the orbit, and medial wall formed by the lateral of the nasal cavity. Frontal and maxillary sinus is the first sinus appears within the few weeks after birth. Frontal sinus, it's not visible radiologically until the age of 2 years, and it reaches the adult proportion by the age of 14. Asymmetry is common in the frontal sinus, and one or both sinus may fail to develop, and absence of both frontal sinus is present with the persistent metopic suture. Ethmoid sinus consists of multiple ethmoid cells divided into the anterior and posterior ethmoid cells. Anterior, posterior ethmoidal air cells are fewer in number and larger in size, drain to the superior meatus. Anterior ethmoid drain to the middle meatus. Basal lamella forming a boundary between the anterior and posterior ethmoidal cells. And we have lamina praecia. It's a thin bone separating ethmoid from the ethmoid bone from the orbit. Sphenoid sinus drain to the superior meatus, and we have turbinates, which are three bony protuberance of each nasal cavity. The superior meatus is adjacent to the superior turbinate, drain the sphenoid sinus and posterior ethmoid cells. Medial meatus is lateral to the middle turbinate. It's a common drainage pathway of the maxillary, frontal, and anterior ethmoid sinus drainage to the osteomeatal unit. Inferior meatus is inferior to the inferior turbinate, drain the lacrimal duct. Cyanonasal disease, acute sinusitis. Acute sinusitis is infection or inflammation of the paranasal sinus. It's a clinical diagnosis. Imaging is only indicated with the presence of the complication sinusitis. And an air fluid level represent the acute sinusitis, but not specific, and mucosal thickening is represent the chronic sinusitis, but may be seen within the acute sinusitis.
So what's the indication for CT scan in sinusitis?
If a complication present.
يعني مو مثل عندنا خبزة دق PNSCT عبارة it's some only in complicated sinusitis. Otherwise no indication for CT scan.
Yes. Bronchocoronal sinus CT scan, note air fluid level with bubbles in the right maxillary sinus constant with acute sinusitis and moderate inflammatory mucosal thickening in the left maxillary sinus, which may result of chronic sinusitis and opacified air cells, ethmoid air cells. Chronic sinusitis is inflammation or infection of the paranasal sinus that lasts at least 12 consecutive weeks. And on this axial CT of the maxillary sinus in patients with chronic sinusitis, there is appreciable thickening of the bone of the posterior lateral of the left sinus. This thickening is the hallmark of chronic sinusitis. Also noted is complete opacification of the maxillary sinus and as a result of mucosal thickening and rapid fluid. No expansion of the sinus is present to indicate the mucocele. Chronic allergic fungal sinusitis is non-invasive disease caused by hypersensitivity reaction to fungi. Most patients with allergic fungal sinusitis are immunocompetent but have a history of asthma. On imaging, the affected sinus is expanded and airless with thin deossified walls. The sinus contents are typically mixed attenuation with heterogeneously curvilinear attenuation. Coronal and axial CT shows marked pan-sinus disease with curvilinear attenuation of the affected sinus. There is erosion of the ethmoid sinus walls.
So you see high density material within the sinus.
Yes.
Is one of two things, either fungal or blood. In cases of trauma, it's blood. If you don't have trauma, then
infection,
you go fungal. And usually it's in diabetics, actually.
Yes. Antrochoanal polyp is a benign polyp extending from the maxillary sinus into the nasal cavity, which characteristic widening of the of involved ostium. It may erode bone and extend into the nasopharynx. Coronal and axial non-contrast CT shows a polypoid lesion involving left maxillary sinus and nasopharynx with erosion of the midline turbinate and medial wall of the maxillary sinus. Mucocele is an expanded airless sinus that results from obstruction of the sinus ostia. May be secondary to inflammatory sinus disease, most commonly, or tumor. Axial non-contrast CT shows expand fluid-filled frontal sinus with thinning of the sinus wall.
Mucocele behaves kind of like a tumor. It destructs, it expands, يعني تشوفين bone destruction و bone expansion كأنه tumor بس it behaves like that. Okay.
An inverted papilloma is a lobulated epithelial tumor of the sinus mucosa. However, it can be associated with the squamous cell carcinoma 10 to 20% of the time. The classic imaging finding, an enhanced study, is cribriform pattern of enhancement, which describe curvilinear gyriform enhancement. In contrast to the mucocele or obstructed secretions, the entire solid tumor will enhance. The tumor tends to remodel the bone. Axial non-contrast CT shows polypoid lesion of the left maxillary sinus with erosion of the medial wall of the maxillary sinus and ethmoid air cells and the turbinate. The sinus is not expand. There is reactive bony sclerosis of the lateral wall of the maxillary sinus. Thank you.
Thank you very much. Good job.
Any questions? ملاحظات شيء؟